अस्सलाम वालेकुम स्टूडेंट्स। जो हमारा टॉपिक है वो है लोअर लिम्ब ब्लॉक्स। हम पढ़ रहे थे रीजनल एनेस्थीसिया हमने पढ़ा है नर्व ब्लॉक्स दो तरफ के, सेंटर नर्व ब्लॉक्स और पेरिफेरल नर्व ब्लॉक्स। सेंटर नर्व ब्लॉक्स में हमने स्पाइनल, एपिड्यूरल और कॉर्डल पढ़ा था। पेरिफेरल नर्व ब्लॉक्स में हेड एंड नेक ब्लॉक्स हमने ख़त्म किए, अपर लिम्ब ब्लॉक्स भी ख़त्म किए और अब हमारा है लोअर लिम्ब ब्लॉक्स। लोअर लिम्ब ब्लॉक्स और थोरैसिक ब्लॉक्स, इनमें उतना ज़्यादा इम्पॉर्टेंस नहीं है क्योंकि ज़्यादातर जो अक्सर ब्लॉक्स करते हैं वो हेड एंड नेक के और अपर लिम्ब के ब्लॉक्स। लोअर लिम्ब में कुछ जो इम्पॉर्टेंट टॉपिक्स है वो मैं आपको वीडियो में फराहम करूँगा, अपलोड करूँगा। ज़्यादा मैं बोलूँगा कौन से ब्लॉक्स आपको इम्पॉर्टेंट है वो भी बोलूँगा, जो आपको याद रखने होंगे ज़्यादातर। बाकी ब्लॉक्स थोड़ा सुपरफिशियली आपको याद रखने हैं। इन दोनों में लोअर लिम्स और थोरैक्स एंड एब्डोमेन में आपको ज़्यादातर सुपरफिशियली याद रखना है। याद तो रहनी चाहिए कौन कौन सी, क्योंकि इनकी अगर एनाटमी, ये ब्लॉक्स तभी समझ आता है जब आपकी एनाटमी क्लियर हो और ये ब्लॉक्स आपको पढ़ने में ईजी आसानी हो जाएगी। याद रहे स्टूडेंट्स, जो लोअर लिम्स ब्लॉक्स है ये ब्लॉक्स हम लोअर लिम्ब में करते हैं, यानी कि नीचे जो लिम्स हैं उनमें करते हैं। उसमें पहला वाला जो ब्लॉक है वो है सियोस मसल्स ब्लॉक। सियोस ये जो मसल है इसमें जो सप्लाई करती है वो सप्लाई करती है लंबर प्लेक्सस। लंबर प्लेक्सस को हम ब्लॉक करते हैं और इस वजह से सियोस मसल्स जो हो जाएगी वो हो जाएगी ब्लॉक और हम सियोस मसल्स वहाँ पे जो सर्जरी होगी थाई में वो हम कर सकेंगे। दूसरा है फिमोरल नर्व ब्लॉक, स्कैटिक नर्व ब्लॉक एंड एब्टूरेटर नर्व ब्लॉक। फिमोरल नर्व ब्लॉक, स्कैटिक नर्व ब्लॉक जो दूसरा ब्लॉक है फिमोरल नर्व ब्लॉक, स्कैटिक नर्व ब्लॉक एंड एब्टूरेटर नर्व ब्लॉक। ये तीन ब्लॉक्स भी करते हैं ये लोअर लिम्स में। अलग अलग फिमोरल नर्व को अलग ब्लॉक करते हैं, स्कैटिक नर्व को अलग ब्लॉक करते और एब्टूरेटर नर्व को अलग ब्लॉक करते हैं। और ये नर्व आइडेंटिफाई करते हैं हम नर्व स्टिमुलेटर से, और फिर ये नर्व ब्लॉक्स हो जाती है और लोअर लिम्स की सर्जरी हो सकेगी इनमें। एंकल ब्लॉक में हम करते हैं एंकल को ब्लॉक, ताकि एंकल सर्जरी जो भी होगी वो हम इजीली कर सकते हैं एंकल ब्लॉक नर्व से, जब भी हम एंकल ब्लॉक नर्व को लोकल एनेस्थीसिया इंजेक्ट कर सकेंगे। बियर्स ब्लॉक, ये आईवी ब्लॉक है, ये थोड़ा इसमें इम्पोर्टेंस ब्लॉक है मगर ये अक्सर नहीं किया जाता है क्योंकि इसमें ज़्यादा हमें लोकल एनेस्थीसिया देना है। 60 to 80 ml लोकल एनेस्थीसिया देना है आईवी के थ्रू। इसको आईवी ब्लॉक भी बोलते हैं। ये अपर लिम्ब एक्सट्रीमिटीज़ को भी करते हैं और लोअर एक्सट्रीमिटीज़ में भी किया जाता है। इसमें याद रहे स्टूडेंट, ज़्यादा ये अक्सर लोअर एक्सट्रीमिटीज़ में करते हैं, लोअर लिम्ब्स में ज़्यादातर करता है बेयर्स ब्लॉक है, इसलिए मैंने ये लोअर लिम्ब्स में रखा है, वरना तो ये अपर लिम्ब्स में भी आता है। लोअर लिम्ब्स में ज़्यादातर इसको जो रोपवाकिन और लेग्नोकिन हम ज़्यादा इंजेक्ट करते हैं, मगर बुप्वाकिन को छोड़ के, क्योंकि बुप्वाकिन कार्डियोटॉक्सिक है। ये अगर नर्व में चला जाएगा तो टॉक्सिसिटी हो जाएगी, कार्डियोटॉक्सिसिटी या सीवीएस की, कार्डियोवास्कुलर सिस्टम की टॉक्सिसिटी हो जाती है और पेशेंट एलर्जिक जो कंडीशन है वो उसमें चला जाएगा। टॉर्निकी इसमें मेनली जो यूज़ करते हैं, जो भी लोकल एनेस्थीसिया हम देते हैं वो आईवी थ्रू, इंट्रावीनस थ्रू देते हैं। और इंट्रावीनस, ताकि हम इसमें टॉर्निकी यूज़ करते हैं ताकि जो लोअर लिम्ब्स को हम ब्लॉक करनी है वो लोकल एनेस्थीसिया सिर्फ लोअर लिम्ब के इंट्रावीनस में रह जाएगा, ताकि वो टॉर्निकी ऊपर वाले साइड में लोअर लिम्ब जो भी हमने ये की, ताकि हम थाई पे टॉर्निकी बांधते हैं या अपर आर्म में, ऊपर अगर अपर लिम्ब में किया तो अपर आर्म में बांधते हैं। और टॉर्निकी क्यों, ताकि अपर जो भी हमने इंजेक्ट किया लोकल एनेस्थीसिया वो आर्म से या अपर आर्म या लोअर आर्म से ऊपर ना चले जाए। इसी वजह से हम क्या करते हैं उसी आर्म को, ताकि लोकल एनेस्थीसिया इसी के सराउंड रह जाएगा और वहाँ पे नमनेस हो जाएगी। टॉर्निकी मेनली जो इन्फ्लेट करती है वो 150 mg अबो सिस्टोलिक प्रेशर। सिस्टोलिक प्रेशर जितना भी पेशेंट का होगा उससे अबो 150 करते हैं, टॉर्निकी का प्रेशर रखते हैं। और ये कब तक, क्योंकि हमें डिफ्लेट करनी पड़ती है, अगर सर्जरी देर तक रह गई तो हम डिफ्लेट करते हैं बीच बीच में, क्योंकि ये टॉर्निकी के फिर इस्कीमिक हो जाएगा वो पार्ट, उस पार्ट को ब्लड सप्लाई नहीं जाएगी और वो सप्लाई इस्कीमिक हो सकता है। उस वजह से हम क्या करते हैं, बीच बीच में टॉर्निकी को डिफ्लेट करते हैं। टॉर्निकी को डिफ्लेट करने के लिए दो ये है, एक तो अपर लिम्ब में अलग है, दूसरा लोअर लिम्ब में अलग है। अपर लिम्ब में डिफ्लेट करने के लिए हमें टाइम हो 90 मिनट्स के बाद या 2 आवर्स के बाद डिफ्लेट करते हैं, याद रहे। ये जो पॉइंट्स है, ये 2 पॉइंट्स ये एमसीक्यूज में बिल्कुल पूछे जाते हैं, इंपॉर्टेंट पॉइंट्स 2 है, याद रहे। ये आया भी बहुत बार है, JKSSB में और सिग्नल्स में भी आया है। डिफ्लेट करते हैं 90 मिनट्स के बाद या 2 आवर्स के बाद, मगर किसमें, लोअर लिम्ब में। और अपर लिम्ब में डिफ्लेट करते हैं 30 मिनट्स के बाद। 30 मिनट्स सर्जरी की हो सकेगी तो उसके बाद हम डिफ्लेट करते हैं और उसके बाद इन्फ्लेट फिर से करते हैं। डिफ्लेट करने के बाद इन्फ्लेट फिर से करते हैं। यही था बियर्स ब्लॉक, जिसको बोलते हैं आईवी ब्लॉक भी बोलते हैं। ये हम ब्लॉक आईवी में देते हैं। ये था हमारा लोअर लिम्ब्स का। लोअर लिम्ब में कोई भी सर्जरी होगी तो ये ब्लॉक्स हम कर सकते हैं। सियास मसल ब्लॉक, फेमोरल नर्व, स्कैटिक नर्व, एब्ड्यूरल नर्व, एंकल ब्लॉक और बियर्स ब्लॉक कर सकते हैं, जो मेनली यहाँ पे लोअर लिम्ब्स में ब्लॉक होते हैं। और जो थोरेसिक एंड एब्डोमेन की, ये हमें मैं इसमें थोड़ा सा आपको बोलूँगा कि इसमें कौन कौन से ब्लॉक्स आते हैं और क्या क्या सर्जरी उसमें हो सकती है, और इसमें थोड़ा मैं आपको अपलोड करूँगा उसमें। ये था हमारा नर्व ब्लॉक्स, या इंशाल्लाह आपको समझ आ गया होगा कि नर्व ब्लॉक्स कैसे ब्लॉक्स करते हैं और ये ब्लॉक्स क्यों करते हैं और इनमें कॉम्प्लिकेशन क्या है, इंडिकेशन क्या है। ये था हमारा रीजनल एनेस्थीसिया।
The popliteal sciatic nerve block is one of the most common blocks performed on the lower limb. It provides excellent coverage of the calf, foot, and ankle and is a solid member of the Plan A block team. The sciatic nerve originates from the lumbosacral plexus and travels down the posterior thigh deep to the hamstring muscles. As it enters the popliteal fossa several centimeters above the popliteal crease, it separates into its 2 principal branches, the tibial nerve and the common peroneal nerve. The tibial nerve lies just superficial to the popliteal artery and vein in the fossa. The sciatic nerve and its 2 branches are covered by a tough membranous sheath that provides a mechanism for the nerve to glide back and forth as the knee and hip joints flex and extend. This has been called the peroneural sheath, or in some circles, the circumneural sheath. Note that it branches along with the nerve itself to mirror the anatomy. It's important to understand that the sheath is not part of the nerve like epineurium is. Here we see the larger tibial nerve and the smaller common peroneal nerve bounded by the peroneural sheath. Each nerve has its own individual epineurium, and so placing a needle within the sheath but outside the 2 nerves themselves, say here, does not represent an intraneural injection. Now, the peroneural sheath is a diffusion barrier, meaning that unlike the brachial plexus sheath, local doesn't travel all that well across it. If your local anesthetic is not within the sheath, you're going to experience a slow onset and a weak block. Conversely, local anesthetic put inside the sheath will ensure a dense, complete block. Finding the right location to perform the block is important to ensure both efficacy and to prevent injury to the nerves. Let's imagine the torso of this figure is our sciatic nerve and the legs are the 2 branches. The pants represent the peroneural sheath. If we image here, the nerves are so close they appear almost as one big nerve. It would be challenging to insert a needle into the peroneural sheath while avoiding impaling the nerve structures. Not a great spot to do the block. Conversely, this distal location finds both branches quite separate, and each branch now has its own peroneural sheath. Local place between them would not diffuse well across the sheath, and you'd end up with a slow, poor block. You want to be here, right as the nerves are separating, but before the sheath has split apart. This gives you a nice, safe, intra-sheath target to aim for. The popliteal sciatic block can be performed in several positions. We prefer lateral as it offers nice ergonomics. The probe is placed on the popliteal crease and slid proximally until you're happy with the image. The needle is then advanced in plane from the lateral aspect. Now, there are two kinds of people in this world, those that stand behind the patient and push with the probe, and those that stand in front of the patient and pull. Despite some vigorous debate between pushers and pullers, it's strictly personal preference. In trauma patients who can't roll on their side, we'll do this supine with the calf and ankle elevated on some blankets, just enough to get the probe underneath the popliteal fossa. Note that your image will look identical to the lateral approach. Here we see the typical sonogram when the probe is placed on the popliteal fossa. A good landmark to start with is the popliteal artery, which is most shallow right at the crease. Superficial to that is the vein, which is often compressed by the pressure of the probe. Above that, we see the tibial nerve, which looks like a chocolate chip cookie, hyperechoic matrix with the dark fascicular chips. At this location, the peroneal nerve may be separated by 1 to 2 centimeters, but in general can be found more lateral and superficial than the tibial nerve. Dynamic scanning is key to identifying both nerves. If you slide the probe proximally and distally along the back of the distal thigh, the nerves will appear to come together, then separate. This makes them easier to distinguish from the background. Now the goal is to choose a location where they're just starting to peel apart, leaving a small space in between for the needle. A needle is advanced in plane from the lateral aspect. Note that we're entering the screen from about 2 centimeters down. That's done so our trajectory won't run right through the peroneal nerve on the way to the target. Aiming the needle between the two nerves, pressure is applied to the peroneural sheath and the needle gradually advanced. Take care not to aim at either nerve. Sometimes the sheath will indent a lot before the needle passes into it. That's okay. A test injection shows flow outside the sheath. We're still not there. There's often a big give as the needle passes into the sheath. We then withdraw the needle tip until it appears to be between the nerves. This time our injection is good. We see the two nerves separating and the tibial nerve being carved out by the local anesthetic. We aim to put 20 to 30 mils in with one injection. No redirection is required. Occasionally it appears like only one nerve is being surrounded by local anesthetic. Don't worry. Remember the pants analogy. If you're inside the pants, the volume will backfill and then go down the other pant leg. After the injection's finished, I like to scan distally to confirm that there is indeed local filling both pant legs. This block provides complete anesthesia or analgesia to the bone, muscle, and skin of the calf, ankle, and foot, with the exception of the skin and small bony contribution at the medial ankle supplied by the saphenous nerve. We use this block routinely for major foot and ankle surgery, ankle fracture repair, bunionectomy, and occasionally for tibial fracture. It's an excellent option for below knee or transmetatarsal amputation too. If the surgery involves any portion of the medial malleolus or skin overlying it, we'll also supplement with the saphenous nerve block at the adductor canal. Here are some tips for popliteal sciatic nerve block. First, if the tibial and peroneal nerves are not well defined on the screen, dorsiflexing and plantarflexing the ankle usually makes the nerves appear to dance. This works well with both active and passive flexion, so the patient doesn't have to be cooperative to take advantage of this. There are times when the prone out-of-plane approach is convenient. There are data to show that catheters don't get displaced as easily when they approach the sheath from this angle compared to the lateral approach. We start by getting that same image, and then a needle is brought out of plane. Just like an out-of-plane vascular puncture, you can quickly estimate the needle path by tissue deformation and safely aim for the point between the two nerves. While you won't see your needle all that well, you can use hydrolocation with saline to help stay safe as you advance. Lastly, the lateral popliteal sciatic block is one of the higher risk peripheral blocks we do from the perspective of nerve injury. This may be because the common peroneal nerve is not seen and accidentally contacted as a needle is advanced. We do know the common peroneal nerve typically comprises 2 to 3 large fascicles rather than a dozen or more smaller ones, which may predispose it to mechanical injury due to the relative lack of epineurial cushioning. Nerve stimulation is a useful adjunct for this block that may give you an early warning of inadvertent needle-nerve contact. The femoral nerve block is often one of the first that beginners learn, and for good reason. It's relatively straightforward and has a lot of utility in both the trauma setting and for elective surgical patients undergoing lower limb surgery. In this video, we'll discuss the anatomy and technique for ultrasound-guided femoral nerve block, as well as blockade of the lateral femoral cutaneous nerve. In the thigh, the femoral nerve lies on the surface of the iliacus muscle, just lateral to the femoral artery. It's bound down to this muscle by the fascia iliaca, a tough fibrous sheath. The lateral femoral cutaneous nerve, or LFCN, passes under the inguinal ligament and over the surface of sartorius before continuing subcutaneously down the lateral aspect of the thigh. Here we see the relationship of the femoral artery and vein to the femoral nerve. Note that there is a separation between the artery and the nerve. The fascia iliaca dives deep under the artery, so these two structures are in different fascial compartments. We see the LFCN in a more superficial fascial plane, running across the sartorius before falling into a small fat pad between the sartorius medially and tensor fascia lata laterally. Here we see the dermatomes, myotomes, and osteotomes relevant to the femoral nerve. The LFCN is a cutaneous nerve and therefore only supplies sensation to the skin of the lateral thigh. We use the femoral nerve block for lower limb amputation, where femoral and sciatic catheters are left in place for 5 to 7 days. We also use it extensively for lower limb trauma, such as femoral fracture and proximal tibial fracture. Note that the medial aspect of the proximal tibia is innervated by the femoral nerve. Other indications include ACL repair and complex knee reconstruction. We'll block the LFCN for elective posterior hip arthroplasty, skin graft harvesting, and other various procedures that involve the skin of the lateral thigh. For the femoral nerve block, the probe is placed in the inguinal crease and the needle advanced in plane from the lateral aspect. You should see the femoral artery, the nerve beside it, and the fascia iliaca binding the nerve down to the iliacus muscle. We'll be advancing the needle from the lateral side. We want to gently hydrodissect the nerve off the fascia iliaca and look for that unzippering. Always use hydraulic pressure of the saline or local anesthetic to do the mechanical work for you. You don't want a sharp needle contact in the nerve. 10 to 15 mils of local anesthetic is a good dose here. Sometimes the nerve peels off the iliacus muscle instead and the local is deep to the nerve. That's totally fine too. We'll often place femoral catheters for ACL repair and trauma. The technique is much the same. You can see the needle here indenting the fascia iliaca. The motor response shows us that we're close to the nerve. However, this first test injection seems to be spreading in the substance of the sartorius muscle. We're still one fascial layer away. Ah, that felt good. Now we see the unzippering. The catheter is advanced through the needle to 1 to 2 centimeters past the tip and the needle removed. You always want to test your catheter with saline or local anesthetic. Air can give you false positives and ruins your picture if you need to do some fine-tuning of the catheter position. The tip is in a good position here. The LFCN is approached in much the same way, just more lateral. It's useful to start at the femoral nerve location where you have easy landmarks. Then, move laterally past the feather-shaped sartorius muscle. Translating the probe distally along the lateral thigh will bring out a fat pad just lateral to the sartorius. This is where the LFCN lives. It looks like a little raspberry. If you image this too proximally, the nerve crawls back up onto sartorius where it gets lost in the fascia. Sliding back distally, we see it once again in that fat pad. A needle is advanced from the lateral aspect. Note our depth of 0.5 centimeter here. It's very shallow. 2 to 5 mils of local anesthetic are deposited within the fat pad with an effort to see the nerve floating in a puddle of local. And here are some tips for blocking these nerves. First, you don't need to kill these nerves with volume. 10 to 15 mils is more than enough for the femoral, and just a few mils easily blocks the LFCN. Secondly, the femoral nerve is quite anisotropic, meaning that different angles of beam incidence will cause it to light up or disappear on the screen. Typically, a cranial tilt will result in the nerve popping out of the background. And finally, the femoral nerve breaks up into tiny branches, or arborizes, quite quickly at the level of the femoral artery bifurcation. If you're having trouble seeing your femoral nerve, slide the probe proximally to be sure that you're at least at the bifurcation or higher, where the nerve is one chunky structure. The femoral and LFCN blocks are easy to perform and both are impactful techniques to have in any regional anesthesia toolkit.
The psoas compartment block is designed to anesthetize the femoral, lateral femoral cutaneous, and obturator nerves. By doing so, this block provides postoperative analgesia for hip and knee surgery. When combined with a sacral plexus block, it may be used to provide anesthesia for lower leg surgery. Lay out the necessary equipment prior to beginning the procedure: a 20 milliliter syringe, a 5 milliliter syringe with 25 gauge needle, sterile IV tubing, and 1% lidocaine. Should you choose to confirm needle placement by nerve stimulation, you will need a nerve stimulator, an electrode, and a 22 gauge 120 millimeter insulated stimulating needle. In addition, you will need sterile surgical towels, sterile prep solution and sponges, gauze, and a marking pen. An ultrasound machine with a low-frequency transducer will be required to perform this procedure. Sterile ultrasound gel and a sterile sheath should be available. The patient should be placed in prone position with a pillow under the lower abdomen to minimize lumbar lordosis. The practitioner should stand on the same side of the patient to be blocked, while the ultrasound screen is placed opposite the physician. Sedation is required to keep the patient comfortable during the procedure. As demonstrated here, the patient needs to be prepped and draped in sterile fashion prior to beginning the procedure. Cover the ultrasound probe with gel and place it inside a sterile sheath. In addition, sterile gel should be spread onto the patient's lower back on the side to be blocked. Place the transducer, with its axis parallel to the spine, at the level of the L4-L5 vertebrae, 3 centimeters lateral to the spinous processes. Move the transducer inferiorly to identify the vertebral interspaces. Repeat this step by moving the transducer superiorly to again identify the vertebral interspaces in this region. Return to the L4-L5 vertebral interspace and rotate the transducer 90 degrees counterclockwise into the transverse imaging plane. Looking at the ultrasound screen, identify the erector spinae at the top of the screen. Deep to the erector spinae is the quadratus lumborum and psoas muscles. The L4 vertebral body is medial to the muscles. The figure illustrates the relationship of the structures you are visualizing on the ultrasound screen. The erector spinae is superficial to the quadratus lumborum and psoas muscles. The needle will pass into the psoas muscles between the transverse processes of the adjacent vertebrae. It has been recommended that the L4-L5 vertebral interspace is the most appropriate level for performing the ultrasound-guided psoas block. The anthropoid pelvis of most men and some women obscures the sonographic imaging below this level. See the text and references for further detail. At the medial edge of the probe, create a skin wheel with 1% lidocaine using the 25 gauge needle. Proceed to insert the needle into deeper tissues. Inject additional anesthetic following negative aspiration. Insert the 22 gauge 120 millimeter insulated needle perpendicular to the skin through the cutaneous wheel. Keep the needle aligned with the transducer. Identify the needle tip on the ultrasound screen. Advance the needle under real-time imaging between the transverse processes of L4 and L5. You can confirm the location of the needle tip using a nerve stimulator. Turn on the stimulator to 0.5 milliamps of current to excite the nerves of the lumbar plexus. Activation of the femoral nerve causes the quadriceps to twitch, which indicates that the needle is correctly located. Aspirate the syringe and inject a test dose of 1 to 2 milliliters of anesthetic, looking for medication spread on the ultrasound screen. A small, expanding hypoechoic area should be well visualized. If you cannot appreciate the injection on the screen, stop immediately. If the test dose indicates correct needle placement, an additional 18 milliliters of anesthetic is administered. Continue to watch the screen to monitor the injection. Carefully position the patient after injection to maintain the patient's comfort and safety. The patient will begin to lose motor control and should be discouraged from attempting to move without assistance because of the risk of self-injury. Assess the degree of anesthesia by performing a neurologic exam. Evaluate the degree of sensory loss in both legs in the L2, L3, and L4 distribution, as these are the nerves affected by the psoas block. Although rare, bilateral anesthesia can occur, causing significant sensory loss and hemodynamic changes.
Ankle blocks are very useful and can get you out of a jam when sick patients present for foot surgery. There are 5 separate nerves that supply the foot below the ankle. Depending on the procedure and the sensory coverage required, you may need to block several or all 5. Landmark-based ankle blocks aren't hard to do. They're basically a ring block of the ankle, but ultrasound confers several advantages such as the ability to visualize and avoid vascular structures, and more importantly, the ability to substantially reduce the volume of local anesthetic required. Landmark-based techniques often call for as much as 20 to 40 mils of local anesthetic. With the ultrasound-guided technique, the whole thing can be accomplished with one 10 ml syringe, or even less in some cases. We see the 5 nerves here and their relative position about the ankle at the level of the malleoli. By far the most important nerve is the posterior tibial nerve, which innervates the sole of the foot via the plantar nerves, the toes, and much of the muscle and ligament of the foot. The other nerves contribute in the pattern shown here, and it's elegant to be able to block just the precise number of nerves you need. Okay, let's dive in. The posterior tibial nerve lives behind the medial malleolus. There are a number of other structures in the vicinity as recalled by the mnemonic Tom, Dick, and Not Harry, which stands for the tendons of the tibialis posterior and flexor digitorum longus, the posterior tibial artery and nerve, and most posteriorly, the flexor hallucis longus tendon. The probe is placed on the ankle just behind the medial malleolus. The needle can be brought in out of plane or from the posterior aspect as patient position dictates. A needle advanced from the anterior aspect almost always encounters the posterior tibial artery and veins, so it's best to avoid that approach. You can see here that the tendons look very much like nerves, so it's important to know what to look for. A good trick is to slide the probe proximally in order to make the tendons disappear. This leaves only the posterior tibial nerve and its corresponding artery. The sural nerve can be found just behind the lateral malleolus beside the Achilles tendon. It innervates the lateral foot. With a light touch on the probe, you should see the short saphenous vein and the raspberry-like sural nerve beside it. Sliding the probe up the posterior calf brings both nerve and vein up onto the Achilles tendon, which helps with identification, but it can be blocked at any location. The deep peroneal nerve can be found deep to the flexor retinaculum on the anterior surface of the ankle. It runs lateral to the dorsalis pedis artery for a time before traversing medially across the foot to innervate the first web space. Here we see the artery and the nerve on the lateral side. A needle slips underneath the nerve along the periosteum and the nerve is lifted off the bone with a few mils of local anesthetic. The superficial peroneal nerve, which innervates the dorsum of the foot, is often anesthetized with a field block across the top of the foot after it's branched multiple times. With ultrasound, this nerve is easily seen about 10 centimeters above the ankle on the lateral calf. The nerve can be seen here hanging off the deep fascia of the leg between peroneus brevis and extensor digitorum longus muscles. The fibula often seems to point at the nerve. As the probe is slid distally, the nerve can be seen piercing the fascia and branching. Our preference is to block it in the proximal location prior to the branching. And finally, the saphenous nerve is another one that's easily blocked by subcutaneous field block just above the medial malleolus. With the ultrasound technique, the saphenous vein is found and local anesthetic placed immediately adjacent to it. This nerve is the least visible of the 5 because it's just so small at this point, but the vein provides a good landmark. Each of these nerves only requires 2 to 3 mils of local anesthetic, providing that it's placed in the intermuscular fascial plane where the nerves live. The exception, we often use up to 5 mils for the posterior tibial, as it's the biggest nerve of the group.
This video will discuss the use of the Beer block or intravenous regional anesthesia in the management of an extremity injury. Please note, Beer is spelled B-I-E-R, not B-E-E-R. Anesthesia produced by B-E-E-R blocks are found elsewhere on the YouTube site, although they probably involve the same patient seen in these videos and probably most of the ED personnel as well. To perform the Beer block, a solution of 0.5% lidocaine is generally employed. To prepare this solution, 1% lidocaine is mixed with equal parts of normal saline. It is important to use lidocaine without epinephrine for this preparation. Marcaine may also be used to perform the Beer block. Generally, the solution that is employed is a 1% solution, which is 10 milligrams per ml of lidocaine, is mixed with equal parts of normal saline. The normal saline is generally obtained from either an intravenous bag or the intravenous flushes that are used for saline locks can be employed as well. They're generally a little bit more convenient and easier to get your hands on. It is important to mix up enough of the solution. Generally for an upper extremity block, it's anywhere between 25 to 50 cc's, and for a lower extremity block, at least 50 cc's is employed of the 0.5% solution. Some people will inject a smaller amount, half the amount of 1% lidocaine, and then follow it with a equal amount of saline as an injection. This technique can be used, although it is probably preferable to mix up the 0.5% solution and use that to perform the Beer block. If you are performing the block on a child, the maximum dose of lidocaine to be used is 4.5 milligrams per kilogram, and the maximum amount of marcaine or bupivacaine that can be used is 2.5 milligrams per kilogram. Once the solution is prepared, an intravenous catheter is placed in the affected arm. It can be placed above or below the injury, it really doesn't matter. It's generally a good idea to raise a little wheel of lidocaine prior to the placement of the intravenous catheter itself. The catheter is inserted like any other intravenous catheter and converted to a saline lock with a access port on the end of it. At this point, it can just be taped into place until you're ready to inject the lidocaine solution.
I'll bring up this one when I'm back.
At this point, arterial tourniquets can be placed to isolate the arm and the affected area once the lidocaine is injected intravenously. It is extremely important that the area of the arm in which the lidocaine will be injected can be completely isolated from the rest of the circulation. Because of the large number of milligrams of lidocaine or bupivacaine that are to be administered, it is important that it does not enter the systemic circulation directly. To help prevent this problem, 2 tourniquets are placed on the patient. Both of them are taped in place and both of them must be arterial. Now, there are commercial systems available which have double tourniquets built into them, but in the emergency department, generally 2 separate tourniquets are placed on the patient. It's a good idea to actually tape the blood pressure cuffs in place. This prevents accidental unwinding of the cuff while the lidocaine is being administered intravenously. The pressure in the cuff is inflated until it is at least 50 millimeters above the patient's systolic blood pressure. Most people will probably take it up to almost 300 to be sure that they are well above the patient's systolic blood pressure. Once the cuff is inflated, the tubing itself is actually clamped. This is because most blood pressure cuffs will leak unless they are firmly clamped into place. So neither the bulb valve nor the actual manometer itself can be relied on to hold the pressure that needed for these patients. Some people will wrap the arm with web roll and put the blood pressure cuff on top of that to make it a little bit more comfortable for the patient. The arm is exsanguinated by wrapping it with a tight elastic dressing as well as elevating the arm to get as much blood out of it as possible. Once this is done, the blood pressure cuffs are inflated to well above the patient's systolic blood pressure. As you can see, The actual manometer is going around once and beyond on this patient. And the tubing is clamped. Again, it is imperative to make sure that the tubing is clamped on these patients. Once that's done, the manometer itself can actually be disconnected from the patient. Once the arm's exsanguinated and the blood pressure cuffs are elevated, the wrapping is removed. Lack of a pulse is documented through use of a pulse ox, which shows no waveform. At this point, the lidocaine solution can be injected into the arm. As the solution is being injected, you can see the veins in the patient actually distend because there's no place for the lidocaine to go other than in those veins with both the arterial tourniquets in place. You also notice how gray and dusky the patient's hands look. After a few minutes, the lidocaine will take effect. It can take up to 10 to 15 minutes to get a really good block in place. But once the lidocaine has taken effect, you can do your reduction or repair your laceration or debride your burn, whatever you need to do to the arm, and the patient will generally have no pain at all.
Okay.
Sorry.
As you can see and hear, this patient is perfectly comfortable as we manipulate his fracture. I assure you he is completely awake and he has not received any sedatives on top of this. This is strictly the beer block that's producing all his anesthesia. You can see a small little laceration on the bottom of his wrist, but this is not an open fracture. And we can manipulate this pretty freely without any difficulty on this patient because his entire arm from that distal tourniquet down is completely numb. After at least 20 minutes, and preferably a little bit longer, of isolation of the lower extremity through the use of the arterial tourniquets, the tourniquets can be deflated and removed. It's generally best to slowly deflate the tourniquets to allow the blood flow to ease into the hand rather than rush back into it. At this point, the intravenous catheter is removed and a sugar tongue splint is placed on the patient following the reduction. The patient's arm will remain anesthetized for up to an hour or longer with lidocaine and for up to 6 hours if bupivacaine is used. The key points in the use of a beer block are, number one, to make sure that you use the double arterial tourniquets and that they remain in place for up to 20 minutes after the lidocaine or the bupivacaine is injected. This allows the drug to be fixed in the tissue so there is no bolus into the systemic circulation, which can result in seizures or other complications from lidocaine toxicity. The other thing to consider on use of the beer block or intravenous regional anesthesia is that it's probably underutilized. Patients with multiple lacerations to their extremity from glass injuries, those with burns, extensive burns that need debridement, and those with fractures that are just difficult to manage with procedural sedation all should be considered candidates for the use of this technique.
You're good.